بسم الله الرحمن الرحيم. الحمد لله رب العالمين، والصلاة والسلام على أشرف المرسلين سيدنا محمد وعلى آله وصحبه وسلم أجمعين. سبحانك لا علم لنا إلا ما علمتنا إنك أنت العليم الحكيم. اللهم علمنا ما ينفعنا وانفعنا بما علمتنا. Dear colleagues, this is the second part of the lecture of imaging of the Sella. We have discussed in the first part the anatomic details and the examination techniques as well as the intracellular pathology. Now we are going to discuss the supracellular anatomy and pathology, to be followed by the paracellular anatomy and pathology. As you can see, there is a lot of anatomic and pathologic lesions that can be seen in the supracellular area, and we will try to discuss all these anatomic details and also the different pathologic entities and how can you reach the differential diagnosis between all these lesions. First, we would like to say something about the anatomic details in the supracellular area. We know that the cella is covered by the diaphragma celli, which is a meningeal covering passing between the anterior and posterior clinoids. Also, we have the supracellular cistern containing CSF and the circle of Willis, the vascular anatomy. Then we have the optic nerves and the optic chiasm. Also, the upper part of the infundibular stalk is present in the supracellular area, and a very important structure which is the hypothalamus and the anterior part of the third ventricle and its recesses. Then if you remember in the sagittal images, especially if they are obtained without contrast injection, and you can easily discriminate in some cases between the anterior and posterior pituitary because of the increased fat content and the triglycerides of the posterior pituitary, which makes this part more brighter in the T1 weighted images. Then you know that this is the infundibular stalk, and the infundibular stalk is continuing to this prominent structure which is known as the mammillary body. The distance between the mammillary body and the infundibular stalk, this area, is known as the tubercinarium. Then you can appreciate a very fine CSF space which is belonging to the third ventricle and is going through the infundibulum, and this is known as the infundibular recess of the third ventricle. Being this the optic chiasm, then this recess is also coming from the third ventricle, as is known as the optic recess of the third ventricle. And in the supracellular area, you can see part of the stalk, you can see the optic chiasm, and you can see CSF, and you can see also the vessels, the circle of Willis, and you can appreciate the region of the hypothalamus, and we will discuss immediately. Look at this magnified image, and this is the pituitary gland, and this is the infundibular stalk. Then you can appreciate the region of the tubercinarium and the region of the mammillary body. Also, you can see the infundibular recess of the third ventricle and the optic recess of the third ventricle. This arrow points to one of the foramina of Monro, and this is what we call the anterior commissure, and the distance between the anterior commissure and the optic chiasm is known as the lamina terminalis. These structures are very important to appreciate the site of the hypothalamus. Then posteriorly, you can see that this is the third ventricle, and this is the aqueduct of Sylvius connecting the third to the fourth ventricle. Then posterior to the aqueduct, you can see the corpora quadrigemina, the superior and inferior colliculi. Then you above this, and you can see the posterior commissure, which is the posterior located structure compared to the anterior one, which is the anterior commissure. Then where is the hypothalamus? The hypothalamus lies actually below the thalamus, and you cannot put your finger on an area that is known as the hypothalamus, but you can imagine the site of the hypothalamus. And if you know that this is the pituitary gland and this is the infundibulum, this is the infundibular recess of the third ventricle, and then the optic recess of the third ventricle, and this is the optic chiasm, and this is the lamina terminalis, and this is the anterior commissure, and here is the posterior commissure, and you see the region of the mammillary body and the region of the tuber cinereum. Then these are the borders, or the imaginary borders of the region of the hypothalamus. Anteriorly, it is formed by the lamina terminalis, this area, the optic chiasm, this area, and the anterior commissure. Anterior commissure, lamina terminalis, optic chiasm. Then the superior aspect of the hypothalamus is just an imaginary line drawn between the anterior and posterior commissures. This is the posterior commissure, and this is the anterior commissure, and you draw a line here. This is the superior aspect of the hypothalamus. Then posteriorly, there is an imaginary line sloping from the posterior commissure to the mammillary bodies here, this area. And the inferior aspect of the hypothalamus is bordered by the infundibular stalk, the tuber cinereum, and the mammillary bodies. Then this area, if you look in the sagittal images by MRI, you can say that this is the region of the hypothalamus, but you cannot say definitely that this is the hypothalamus itself. Then the supracellular lesions are too many, as I have said, but we have common lesions and relatively less common lesions. The most common lesions in the supracellular area depend on the age of the patient. If you are dealing with a child, then there are two common lesions, which are the craniopharyngioma and the hypothalamic glioma. In cases of adult, the supracellular meningioma comes next to the extension, the supracellular extension of the pituitary adenoma. Then aneurysms are equally distributed in both ages, and aneurysms are considerably common in the supracellular area because of the presence of the circle of Willis in this particular anatomic structure. Starting by lesions arising in the pediatric age group, and then we have the craniopharyngioma and the hypothalamic glioma. Craniopharyngioma represents about up to 3% of intracranial tumors. It has two peaks, one in the pediatric age group from 6 to 10 years, and another peak in the adult group about the age of 50 years. This lesion is occurring in the supracellular area. It may extend into inside the cell, and in the children it represents about 50% of the supracellular tumors, and usually presents by signs and symptoms of increased intracranial tension. For the diagnosis of this lesion, we have three major components. The first one is the cystic component, the second one is a solid component, and the third one is the presence of calcium. And whenever you see a supracellular space occupying lesion composed of three components, the cystic component, solid component, and calcification, one of the common diagnoses here is the craniopharyngioma. The craniopharyngioma, we have three main types. The first and the commonest type, which is the adamantinomatous type, and this is the regular type seen in the pediatric age group. And the second type is the squamous papillary type, which is usually seen in adult. And the third type is a mixture between both. The adamantinomatous type, or let us say the regular craniopharyngioma, is more common, is commonly seen in children. It is composed of the three major components I have said, which are the cystic component, the solid component, and the presence of calcium. And then the solid component usually shows enhancement, and it may encase the vessels located nearby. The squamous papillary type is less common. It's usually seen in adults, and it is usually solid with some areas of breakdown inside, but there is no cystic component, and there is no calcification. Then solid craniopharyngioma, which is the less common type, is seen as a mass in the suprasellar area. This is pre-contrast and this is post-contrast. The mass is almost homogeneously enhanced, showing some areas of breakdown inside the lesion. But the commonly seen in the clinical practice, which is the adamantinomatous type of the craniopharyngioma, is composed of three major parts: the cystic component, and the solid component, and the presence of calcium. Sometimes one of these components is missing. Still, you can diagnose the suprasellar craniopharyngioma if you see a suprasellar mass made of predominantly having a cystic component and calcium, or a cystic component and a solid component. And you remember that the MRI is almost insensitive for detection of calcium. Then, and for the diagnosis of craniopharyngioma, you depend on the other two main features, which are the cystic component and the solid component. This is a pre-contrast study showing a cystic lesion in the suprasellar area, and there is a solid component which is intensely enhancing after contrast injection. You can easily appreciate that the lesion is quite separable from the enhanced pituitary gland. And this is also a craniopharyngioma by MRI: sagittal T1, coronal T2, sagittal T1 post-contrast, and axial T1 post-contrast. The presence of a suprasellar lesion, and the lesion is made of a cystic component and the solid component. The lesion is not clearly separable from the pituitary gland. Then you are dealing with a craniopharyngioma. In the CT scan, you are able to appreciate the presence of calcium, and there is a cystic lesion in the suprasellar area with calcification. Then you are dealing with craniopharyngioma. And you know that the fluid inside the craniopharyngioma cyst may be of high protein content, so that it will appear of bright signal in the T1 weighted image, and also of bright signal in the T2 weighted image. And there may be some fluid level inside the cyst itself. Then you remember the Rossix cleft cyst, which is a congenital lesion arising from the remnants of the the craniopharyngeal duct, and this cyst is predominantly inside the cella. The cyst do not show calcium, and it has no solid component, and usually shows no enhancement, and if any, there is minimal enhancement of the wall. And this is a classic appearance of a Rossix cleft cyst, which is predominantly inside the cella, extending slightly above the cella. But the craniopharyngioma is a predominantly suprasellar pathology. It has a cystic component and a solid component. If you inject the contrast, the solid component will enhance, and the cyst wall will also enhance. And sometimes the fluid inside the craniopharyngioma cyst may show hyper intense signal in T1 due to the high protein content or the proteinaceous content. Then we came to the second lesion seen in the children, which is the hypothalamic glioma. In the hypothalamic glioma, in order to understand this, you should know something about the visual pathways. And we will discuss some of these pathways in the lecture of orbital imaging. But you know that this is the optic nerve and this is the optic chiasm. Then you got the optic tract and the visual radiations in the occipital cortex. Then the optic nerve or the optic gliomas and the hypothalamic gliomas are lesions which affect the visual pathways. These lesions do not contain cystic component, they do not contain calcium, they are solid, and in many times they show homogeneous contrast enhancement. In the T1 they appear iso-intense, in the T2 they appear hyper-intense, and they do not show hemorrhage, and the enhancement is usually homogeneous but may be heterogeneous. This is a good example of hypothalamic glioma in a child 8 years old. You see a supracellular lesion which is almost homogeneously enhanced and is quite separable from the pituitary gland, and this is the infundibular stalk, giving the sign which is known as the figure of 8 configuration. This is the tumor and the infundibular stalk and the pituitary gland. Then this is the hypothalamic glioma in a child 10 years old. Intermediate signal in the T1, bright signal in the T2, and almost homogeneous post-contrast enhancement in the coronal and sagittal T1 weighted images. You can appreciate the separation on the of the lesion from the pituitary gland. This is the normal pituitary gland, the cavernous sinuses, and this is the tumor. Then, if you see a lesion in the supracellular area, and you remember if this is a child, you are in the diagnosis of one of two, the craniopharyngioma and the hypothalamic glioma. The craniopharyngioma is predominantly cystic. It contains a solid component and they may show calcium. The hypothalamic glioma is almost a solid lesion that is infiltrating the visual pathways. Here it arises from the hypothalamus and may involve the optic chiasm as well. And this lesion, you can see a small cystic component and a large solid component. Then what are the differences between hypothalamic glioma and the craniopharyngioma? The glioma is usually solid with no internal calcification. Craniopharyngioma has a major cystic part and the calcium is usually present. The lesion is of low signal in the T1. Sometimes the cyst of the craniopharyngioma shows high signal in the T2. The lesion, the glioma may show heterogeneous or homogeneous post-contrast enhancement, and here the enhancement will be shown only by the solid component and maybe the cyst wall. This lesion infiltrates the visual pathways and is associated with neurofibromatosis type 1 in about 20 to 50% of cases. The craniopharyngioma has no relation to the visual pathways and has no relation to the neurofibromatosis type 1. Then neurofibromatosis type 1 is an autosomal dominant disorder, and about 50% of the patient had positive family history for this lesion. In cases of neurofibromatosis type 1, we can identify lesions along the visual pathways, starting from the optic nerves, the chiasm, the tract, and the visual radiations. And these lesions may be one of two. Either they are hamartomas or they are gliomas. In cases of hamartomas, you can see the lesions are not surrounded by edema, exerting no mass effect and do not enhance. And if the lesions are enhancing, you are in the diagnosis of gliomas rather than hamartomas. In neurofibromatosis type 1, you see infiltrative pathology along the visual pathways along the lateral border of the thalamus on both sides, and this is T1 and this is T1 post contrast. The lesions are enhancing, then you are dealing with gliomas. And when we are discussing the orbital pathology, we will say that the enlargement of the optic nerve, tortuosity of the optic nerve, and the enhancement is usually suggestive of an optic nerve glioma. But in this patient, 6 years old, you have involvement of both optic nerves together with an enhancing mass in the supracellular area infiltrating the region of the chiasm, and also see enhancement lateral to the thalamic area going across the visual pathways, diagnostic of neurofibromatosis type 1. Then in cases of adult, one of the common, or let us say the most common supracellular lesion seen in adults is the extension of the pituitary adenoma. You remember that the usual or the most common extension of the pituitary adenoma is through the supracellular area. And first it will obliterate the supracellular cistern, then it will compress the chiasm, and then it will compress the hypothalamus. And this is an example you remember from the first part of this talk. You see this is a pituitary adenoma showing homogeneous enhancement extending into the supracellular area and reaching the level of the chiasm. These are the internal carotid arteries, and I have said, in order to know that the pituitary adenoma has involved the cavernous sinus, you should see a tumor tissue lateral to the internal carotid artery. In this case, no, this is the normal homogeneous enhancement of the cavernous sinus itself. And this is also another example of supracellular extension of pituitary adenoma. This is before contrast and this is after contrast. You see obliteration of the supracellular cistern, compression and the stretching of the chiasm over the superior aspect of the lesion. Then supracellular meningioma is a tumor of adults. It arises in the supracellular area from the diaphragma celli, or in the region of the anterior clinoid. The meningiomas, as you all know, are more common in females, and this tumor is considered the second most common supracellular lesion in adults. Similar to any other meningioma, the tumor will show homogeneous post-contrast enhancement. It will show the lobulated outline. It may contain calcium. It may be associated with enhancing dural tail, and may also associated with bone sclerosis of the adjacent bones. And this is a supracellular meningioma. The tumor is located above the pituitary and is clearly separable from the pituitary gland. And after contrast injection, you see homogeneous post-contrast enhancement with a small dural tail along the floor of the anterior cranial fossa. And this is another example of a supracellular meningioma. The tumor is clearly separable from the pituitary gland. The tumor shows homogeneous enhancement, and the arrow points to the dural tail, which, as you all know, is not pathognomonic for the meningioma, but it may help in the, or may support the diagnosis. Then this is an isointense lesion in the T1, and in the T2, after contrast enhancement, it shows homogeneous contrast enhancement. And this is a meningioma of the anterior clinoid, and here is the coronal image. You can see the pituitary gland is separable from the tumor in the supracellular area. Then this is the difference between pituitary adenoma extending into the supracellular area and the supracellular meningioma. In cases of meningiomas, you can appreciate the clear separation between the tumor and the pituitary gland. But in cases of pituitary adenoma extending supracellary, then you cannot see the lesion separable from the pituitary gland. Then we came to the aneurysms, which are seen in the supracellular area. Aneurysms are of the saccular type, of course. They arise at the bifurcation of the arteries, especially in the region of the anterior communicating artery, and also along the course of the middle cerebral artery. And you remember that I have explained this in full details in the case of intracranial vascular pathology, but you should know that the suprasellar aneurysm is similar to any other aneurysm all over the body. It may show homogeneous post-contrast enhancement if it is not thrombosed, and it may show also mural calcification in some cases. You should know also that aneurysms are located slightly off the midline because they arise from the bifurcation of the vessels, while most of the suprasellar pathology is usually located exactly in the midline. CT angiography and MR angiography are helpful in the delineation of the aneurysm and confirming the diagnosis and show the neck of the aneurysm, which is important for the treating physicians. And this is a coronal and sagittal reconstructed images of CT carotid angiography. And you can see the carotid artery in the suprasellar area. You see a big aneurysmal sac connected to the region of the anterior cerebral artery. Also, remember that one of the most helpful diagnostic criteria for an aneurysm is the presence of these whirly artifacts, especially seen in the T2 weighted image due to turbulence of flow of blood flow whenever it passes through the aneurysm itself. Also, you know that aneurysms may got some internal thrombosis, especially if they are giant. And you remember that the giant aneurysm is by definition is that aneurysm which is more than 2.5 centimeter in size. This is a giant suprasellar aneurysm. It shows a patent lumen and a thrombosed lumen showing different CT densities because of the different ages of the thrombus. Then suprasellar dermoid cyst. Dermoid is one of the midline structures and midline pathologies, and it is usually diagnosed by the presence of fat and calcium. And you should remember that MRI is insensitive or less sensitive for the detection of calcium. Then for the diagnosis of these lesions you may need CT. Then this is a suprasellar lesion which is containing fat and the calcium, and I have said also whenever you are diagnosing an intracranial dermoid cyst, you should look in the subarachnoid space for leakage of fat globules within the subarachnoid space. The detection of these fat globules is better by MRI because of the difference in signal between CSF and fat, but in the CT scan the main advantage is the detection of calcium inside the wall of the lesion. This is an MRI of a suprasellar dermoid cyst. The calcium is bright in the T1 weighted image. Other parts of the cyst are less bright in the T1 weighted image. Then if you look carefully in the quadrigeminal cistern, you can see fat globules. In the sylvian fissure, you can also see the fat globules. Suprasellar epidermoid cystic is also a known lesion in the suprasellar area, and you remember that the epidermoid cyst is a cyst containing fluid like CSF. It will appear low signal in the T1, high signal in the T2, but in the FLAIR images the epidermoid cyst will not show similar signal to that of the CSF because of the different components of the cyst content. Also, you remember that the lesion will appear hypodense, similar to the CSF and the CT scan. One of the important features for diagnosis of epidermoid cyst is the lobulated outline. Then, in order to discriminate between arachnoid and the epidermoid cysts in the supracellular area, the main diagnostic features will include: number one, the epidermoid cyst will not show CSF-like signal in the FLAIR images, and whenever you use diffusion-weighted images, the arachnoid cyst will show free diffusion, while the epidermoid cyst will show restricted diffusion. The arachnoid cyst surface is usually smooth, while the surface of the epidermoid cyst is usually lobulated. Then from the anatomy, remember, this is the mammillary body, and this area is known as the tuber cinereum. There is a known lesion here, which is called the tuber cinereum hamartoma, or the hypothalamic hamartoma. You remember that the tuber cinereum is one of the borders of the hypothalamus. The tuber cinereum hamartoma is a benign lesion arising from the region of the tuber cinereum. It is common in boys more than girls, and usually presents by precocious puberty and sometimes seizure, and both presentations may be present. This lesion is typically non-enhancing, and you see a lesion in the region of the tuber cinereum between the infundibular stalk and the mammillary bodies. After injection of contrast, this lesion do not enhance, and it do not contain calcium. This is diagnostic, and it may be considered as a spot diagnosis whenever you see a supracellular lesion related to the tuber cinereum. This is the mammillary body, and this is the infundibular stalk, and the lesion is not enhancing, then the diagnosis is almost certain. And this is also another example, a lesion in the supracellular cistern, and in the coronal image you see the lesion which is not enhancing. Of course, the appearance of the lesion in the sagittal images is more better, because you see the tuber cinereum more better in the sagittal images. Arachnoid cyst can also occur in the supracellular area, and the arachnoid cyst here will contain CSF. It will show a smooth margin, and it will show CSF signal in the FLAIR images. Also, it will show free diffusion on diffusion-weighted images. This cyst do not contain septation, do not enhance, and also do not contain calcium. Then the third ventricle, especially the recesses, are related to the supracellular area, the infundibular recess and the optic recess. Then you know that colloid cyst is one of the lesions arising inside the anterior part of the third ventricle, and is usually seen in relation to the supracellular area. The colloid cyst is diagnosed by its characteristic anatomic location and the density. The lesion is exactly present in the midline along the anterior part of the third ventricle. It shows hyperdensity in the pre-contrast images, and minimal or no contrast enhancement after injection of contrast. By MRI, the colloid cyst can show any signal depending on its content. It can be bright in the T1 and T2, can be black in the T1 and T2, can be bright here and black here, and the opposite is also true. And this is the classic appearance of a colloid cyst, typical location, and a bright signal in the T1 and bright signal in the T2 weighted images. Supracellular germinoma, or is known as ectopic bilineoma, and the presence of supracellular germinoma together with a biennial germinoma, the incidence is about 6 to 12% of cases. 8% of germinomas occurring in the biennial body, and 20% occurring in the supracellular area. But if you see a lesion in the supracellular area, and this lesion is homogeneously enhancing, and if this is a child, you may call this as a hypothalamic glioma. But whenever you see another lesion in the biennial body, then the diagnosis should be germinoma. Germinoma in the biennial body, and the germinoma in the supracellular area. Then other germ cell tumors that can be seen here, like embryonal cell carcinoma, Yolk cell tumor, choriocarcinoma, and teratomas, but germinoma is one of the well-known lesions here. Then suprasellar lipoma, a small fat-containing lesion in the suprasellar area. The lesion will show fat density on CT and fat signal on MRI. It will not enhance, and it is located usually adjacent to the mammillary bodies. One of the helpful techniques is to use the fat suppression MR images, and then you got a low signal of the lesion. And this is a lipoma in the suprasellar area. It is located near the mammillary bodies, and this lipoma is adjacent also to the region of the tuber cinereum. Then suprasellar neurosarcoid. And you remember from the lectures of the brain imaging that sarcoid has a certain affinity to the region of the hypothalamus, the tuber cinereum, and the mammillary bodies together with the infundibular stalk. And the diagnosis of neurosarcoid is usually somewhat difficult unless you have other stigmata of the sarcoid in the body, especially in the chest. Sarcoid is a chronic inflammatory granulomatous disease of unknown etiology, and it may present by diabetes insipidus and the cranial nerve affection, especially the optic nerve. Then in the brain, you can see leptomeningeal thickening and enhancement. There is thickening of the hypothalamic region, tuber cinereum, mammillary bodies, and the infundibular stalk together with enhancement. Then if you see a lesion in the region of the pituitary gland predominantly affecting the infundibulum, and the infundibulum is in this case is thickened and enhanced, one of the differential diagnoses here is to consider the possibility of sarcoid. And here you see the region of the optic chiasm is the seat of a strongly enhancing lesion, and you may also feel that the infundibular stalk is relatively thickened. Then one of the possibilities is the neurosarcoid. And this is a patient known to have chronic lung problems, and this may lead you to think of the possibility of sarcoid. Here, this is the pituitary gland, which is pre-contrast, and after contrast, you got thickening and the enhancement of the infundibular stalk. Then you see here on follow-up study that the lesion has progressed, and there is more thickening of the stalk and more affection of the pituitary gland. Then one of the lesions that can also be seen in the suprasellar area is the histiocytosis or Langerhans cell histiocytosis. This is a disorder of the reticuloendothelial system, and it's rare to occur in the to involve the CNS, when the involvement here can be seen in patients with already diagnosed histiocytosis. In about 10 to 50% of cases, the lesion usually affects the skeleton, and it will present by multiple geographic osteolytic lesions affecting the calvarial bones, the skull base, the petrous bone, orbits, and the facial bones. The most common symptom here is diabetes insipidus, and the most common imaging features are well-defined osteolytic lesions in the calvarial bones, involvement of the pituitary stalk and the hypothalamus, mild infundibular thickening to the frank hypothalamic mass. Of course, the calvarial pathology will help you to predict the nature of histiocytosis here. And you see that this is the pituitary gland, and the infundibular stalk is slightly thickened, but the CT and MRI, you see this osteolytic lesion in the temporal bone, and you see the enhancement soft tissue component surrounding the osteolytic lesion. The clinical findings include diabetes insipidus and tender bulbable skull masses due to osteolytic lesions, proptosis due to encroachment on the orbital cavity by the soft tissue component of the lesions, cerebral or cerebellar dysfunction. And this is a child 6 years old with here the pituitary gland is good, but the infundibular stalk is slightly prominent. Then the history of diabetes insipidus is one of the good predictor factors for the diagnosis of histiocytosis. And in this example, you see the pituitary gland is more or less good, but the infundibular stalk is markedly thickened and enhanced. Then histiocytosis is a multi-system disease with thick enhanced pituitary stalk is the most common CNS manifestation. And you see here, this is the pituitary gland, which is good. The stalk is enhancing. Solitary eosinophilic granuloma has the best prognosis, and the spontaneous remission of a single lesion is known to occur. Multifocal and the systemic histiocytosis has a mortality of about 20% of the patients. Then there is also another lesion which is known as lymphocytic hypophysitis, which causes thickening of the pituitary stalk, but it presents in older age group and commonly seen in later stages of pregnancy and postpartum period. Then what is the difference between sarcoid and eosinophilic granuloma? In cases of sarcoid, this is a chronic inflammatory disease of unknown etiology. It usually presents in the third and fourth decades of life. It may be associated with diabetes insipidus and the cranial nerve affection. There is thickening and the enhancement of the infundibular stalk. It may also affect the hypothalamus, the tuberosinium, and the mammillary buds. The eosinophilic granuloma is usually seen in the pediatric age group, and also the lesion will present by diabetes insipidus. The presence of lytic bony lesions will help in the differential diagnosis, and also the presence of exophthalmos due to encroachment on the orbital cavity will also help in the differential diagnosis. Then in both conditions, you will see thickened, enhanced infundibular stalk. Hypophysitis, as I have just mentioned, is a lesion which is seen in older age group, and it affects the female patients usually in the postpartum area or period. Then infection or systemic diseases are infrequent causes, but this lesion is usually idiopathic. We have 3 histopathologic conditions: lymphocytic hypophysitis, granulomatous hypophysitis, and densitomatous hypophysitis. Lymphocytic hypophysitis occur more often in females, as I have mentioned, and they occur at the end of pregnancy or in the postpartum period. Then the presentation here is by endocrine dysfunction. Lymphocytic hypophysitis, there is enlargement of the pituitary gland, there is involvement of the stalk, and both the gland and the stalk will show homogeneous enhancement. This is also lymphocytic hypophysitis, and you see the pituitary gland and the stalk are relatively prominent and enhancing. This is also a lymphocytic hypophysitis, and you see enlargement and of the pituitary gland, thickening of the stalk, and both are diffusely enhancing. Also, you see in this region a biennial cyst. I hope you remember that this is an incidental finding. Then the differential diagnosis of thickened, enhanced pituitary stalk, or a mass centered in the region of the stalk. Then you remember that germ cell tumors, lymphocytic hypophysitis, lymphoma, TB and sarcoid, and Langerhans cell histiocytosis. Then if this patient is a female patient in the late pregnancy and early postpartum period, you may think of lymphocytic hypophysitis. If this is a child, And you see osteolytic lesions in the calvareal bones. You think of Langerhans cell histiocytosis. And if this is an adult, maybe if female patient, and you see the presentation by diabetes insipidus and cranial nerve pulses, then you may think of sarcoid, particularly if the brain scans showed leptomeningeal thickening and enhancement. The supracellular hotspot is a bright lesion in the T1 weighted image seen in the supracellular area. One of the common lesions here is the ectopic posterior pituitary. The ectopic posterior pituitary, you know, the posterior pituitary is bright in the T1 weighted image. It is usually seen posterior to the anterior pituitary, but sometimes it is located in the supracellular area near the tip of the upper end of the infundibular stalk. Also, the supracellular lipoma will show bright spot. The supracellular dermite cyst may show this, and if there is a vessel that is thrombosed, it will show bright signal because of the clotted blood, and also is very small craniopharyngioma may show bright signal due to the proteinaceous content of the fluid in the cyst. This is an example of ectopic posterior pituitary. This is the anterior pituitary, and you cannot see the posterior pituitary at its normal site. And this is the frequent site of an ectopic posterior pituitary. You remember that metastatic deposits can affect any part of the sella and the cellular region. It can affect the pituitary gland. It can affect the supracellular area, the hypothalamus, the chiasm, and the infundibular stalk. For the diagnosis of metastasis, the known primary malignancy is one of the helpful diagnostic issues. And this is a mass in the region of the optic chiasm, and the mass is strongly enhancing. This is a female patient, and she has a breast carcinoma. Then you consider the possibility of metastasis. And this is also a female patient with breast cancer, and there is a mass centered to the region of the chiasm, slightly to the right side, which is representing metastatic deposit. Then finally we came to the region of the paracellular area, and you know this is the region of the cavernous sinus. And the cavernous sinus is covered by meninges. It contains some of the cranial nerves as well as the intracavernous part of the internal carotid artery. The lesions commonly arising here are the meningioma and the schwannoma, usually arising from the Gisserian ganglion, which is the ganglion of the trigeminal nerve, or the presence of carotid cavernous fistula when the carotid artery opens into the sinus, and the cavernous sinus thrombosis. These are the lesions which can be seen in the paracellular area, together with extension of the pituitary adenoma into the cavernous sinus, aneurysms of the carotid artery, and cavernous sinus thrombosis, paracellular chordoma, and of course metastatic deposits. And the anatomic structures located in the paracellular area include the internal carotid artery, the cranial nerves, the third, the fourth, and the fifth, as well as the sixth cranial nerves, then the dura, and the bones of the skull base. In a lesion arising in the paracellular area, and you have to point the extensions of the lesion. There is a mass in the left paracellular area. You should look for anterior extension into the orbital apex, medial extension inside the sella, posterior extension into the prepontine cistern, and you should assess the orbits for tumor extension, proptosis, and dilated veins. And this is very important in the diagnosis of carotid cavernous fistula. Then paracellular meningioma represents about 10% of meningiomas, and similar to any other meningioma, it will show homogeneous post-contrast enhancement. It will show the dural tail. It may show calcium, and this is an important issue, which is bone sclerosis of the adjacent skull base bones. And you can compare this area adjacent to the meningioma by this area on the opposite side. You can easily appreciate the degree of bone sclerosis that is located here. Then this is the paracellular meningioma occurring in the region of the cavernous sinus. You can see the dural tail, and you can see the vascular encasement. You remember that meningioma can cause cuffing of the vessel, meaning attenuation of its lumen, compared to the extension of the pituitary adenoma, which does not cuff the vessels. This is the coronal non-contrast T1 weighted image, post-contrast coronal and sagittal. This sagittal shows the enhancing dural tail along the anterior and posterior aspects of the lesion. In the region of the cavernous sinus, the meningioma has cuffed the intracavernous part of the internal carotid artery. You see marked attenuation of the vessel lumen compared to the lumen on the opposite side. Then the trigeminal nerve schwannoma, which is arising in the paracellular area. It is considered the second most common schwannoma after the acoustic schwannoma, of course. The presentation is by facial pain, weakness of the muscles of mastication, and the lesion will follow the course of the nerve. You know, the nerve arises from the brain stem going into the cerebellopontine angle, then it goes through the skull base foramina into the paracellular area involving the Gisserian ganglion. There are some points here to be mentioned for to differentiate between meningioma and paracellular trigeminal neuroma. The first is involvement of the Gisserian ganglion, meaning that the lesion is a neuroma. The Gisserian ganglion is a low signal structure present in the Meckel's cave posterior to the cavernous sinus. This is the normal Gisserian ganglion here, and here you can see that the ganglion is no more seen. It is involved by this mass, and this is a supportive sign of the diagnosis of trigeminal neuroma. Then the dumbbell configuration with posterior fossa component. You know, the tumor will follow the course of the nerve. It will show a mass in the cerebellopontine angle, then going through the skull base foramina, and another mass in the paracellular area. The dumbbell configuration, together with involvement of the Gisserian ganglion, are supportive criteria for the diagnosis of trigeminal neuroma. Also, if you see a paracellular mass that is seen in the coronal images extending through the skull foramina to have an extracranial component, and this is also one of the helpful diagnostic criteria. And this is a lesion which is a dumbbell configuration, low signal in the T1, high signal in the T2, and a heterogeneous post-contrast enhancement, diagnostic of trigeminal schwannoma. And this axial image will show the normal Gisserian ganglion on the left side. The Gisserian ganglion is involved by the mass on the right side, which has two components, one in the cerebellopontine angle and one in the paracellular area. Then this also shows the free Gisserian ganglion on the left side and the involved ganglion on the right side. Paracellular chordoma is a known lesion, and you remember that chordomas usually arise at the terminal segments of the vertebral column, but chordoma can also be seen in the paracellular and in the retrocellular area. You also remember that chordomas usually show a fluid-like signal in the T2 weighted image, and this is one of the helpful diagnostic criteria. In the T1, you see a lesion of mixed signal intensity, and in the T2 weighted image, you see hyperintensity similar to fluids. And if you inject a contrast, the lesion will show heterogeneous pattern of contrast enhancement. Then this is a good example of paracellular chordoma. You see a solid mass in the paracellular area on the right side. In the T2 weighted image, you see very bright signal similar to fluid. And after contrast injection, you see heterogeneous post-contrast enhancement. From the T2 weighted image, you may feel that this is a simple CSF containing cyst, but no, it is solid in the T1 and shows enhancement after injection of contrast. This is also a paracellular lesion, which is a little bit bright in the T2 weighted image with some intermediate signals may represent the calcification or flicks of bones inside, and the lesion shows heterogeneous post-contrast enhancement. Carotid cavernous fistula, meaning that there is fistulous communication between the intracavernous part of the carotid artery and the cavernous sinus. The causes are usually traumatic in most of the cases, but arteriosclerosis of the artery may weaken the arterial wall and lead to the fistula, congenital defect in the arterial wall, or if the artery is involved by an aneurysm and the aneurysm has ruptured inside the cavernous sinus, it will result in the same issue. Then one of the important signs for the diagnosis of carotid cavernous fistula is that whenever the artery is communicating with the sinus, then the pressure inside the sinus will be elevated, will be an arterial pressure. Then the draining veins inside the sinus are no more able to be to evacuate the blood in the sinus. Then the veins will be congested and dilated. One of the most important veins here is the superior ophthalmic vein, and the superior ophthalmic vein will be enormously dilated and tortuous. And then if you see that the cavernous sinus is enlarged, it is homogeneously enhanced, and the superior ophthalmic vein is significantly dilated, and they know that this is a carotid cavernous fistula. Then you have two types of this fistula. The direct fistula involves the internal carotid artery and the cavernous sinus, while the indirect fistula involves the dural branches of the external carotid artery and the cavernous sinus. In this indirect fistula, the sinus will not be so much enlarged, and also the superior ophthalmic vein will not be so much dilated. Then here in the CT scan, you can see a enlarged left cavernous sinus with homogeneous CT density. In the angiogram, you see the sinus is dilated, containing flow, and the superior ophthalmic vein is considerably dilated. And here also you can see enlargement of the cavernous sinus on the left side with considerable dilatation of the superior ophthalmic vein compared to the normal superior ophthalmic vein on the opposite side. The clinical manifestations of carotid cavernous fistula have been mentioned previously, but they include pulsating exophthalmos, orbital bruit, motility disturbances in the ocular muscles, then chemosis and glaucoma, visual loss of untreated direct and indirect in about 25% carotid cavernous fistula. Then this is a CT scan of carotid cavernous fistula on the left side with enlargement of the sinus, homogeneous enhancement, and dilated superior ophthalmic vein. By MRI, you see the flow void signals within the sinus and the dilated superior ophthalmic vein. And this is also a case of carotid cavernous fistula on the right side. There are flow voids within the cavernous sinus and the dilatation of the superior ophthalmic vein in the orbital cavity. Then cavernous sinus thrombosis is a rare lesion caused by infection in the face or ear in the sinuses, especially the sphenoid sinus. Sphenoid sinusitis may go to the region of the cavernous sinus, resulting in cavernous sinus thrombosis. This is the clinical presentation: preorbital pain, proptosis, venous congestion, and ophthalmoplegia. In these conditions, you see that the sinus is enlarged, but being thrombosed, it will lose its normal enhancement. It will appear hypodense, and only the internal carotid artery will show enhancement, as you can see here. And you may detect inflammatory changes and congestion in the orbit. Then here is an extensive case of bilateral cavernous sinus thrombosis and bilateral thrombosis of the superior ophthalmic vein. You see extension of the thrombus into the superior ophthalmic vein here, and another thrombus into the opposite vein. Then metastasis, as I have said, can occur in the sella, in the supracellular, in the paracellular area, and you need the known history of primary malignancy for the diagnosis of metastasis. In this example, you see a mass in the region of the right cavernous sinus or in the paracellular area on the right side, and also you can see faintly enhancing lesions in the cerebellum. In a patient with melanoma, these will represent metastatic deposits. Alhamdulillah Rabbil Alameen. Thank you very much.